So again, I am Margil Tahum, and I'm going to discuss to you the nursing diagnosis and related interventions. Touching the vernix caseosa with bare hands can cause infection into the newborn. So we should make sure to wear gloves and make sure that the gloves that we will wear is clean as well. Then second, for infection precaution, is we're going to grasp the newborn through the blanket with one hand under the back and the other around a leg while holding a warm sanitary blanket. So this is all important to prevent infection to the newborn. Actually, we're going to tackle 3 nursing diagnoses, and this is the first nursing diagnosis that we're going to talk about. So this is risk for ineffective thermoregulation. What is the interventions into this nursing diagnosis? We have to keep the newborn warm. So how are we going to keep the newborn warm? We're going to keep the newborn warm by swaddling a newborn loosely with a clean blanket and dry blanket after gently rubbing the newborn dry. Then, make sure that the baby has a cap on his or her head, and we're also going to have the parents hold the newborn. And in this, we're going to inquire the parents if whom among them is going to hold the newborn. So, all of these actions aid in prevention of heat loss. Swaddling appears to provide a sense of security by stimulating the tight confines of the uterus and allowing infants to sleep for extended amounts of time. Also, by letting the parents hold the newborn, so the baby or the newborn will have the heat that the newborn need, and this will also allow bonding. So the time immediately following a kid's birth is critical for parents to begin interacting because their child at this time is very alert and respond well to their parents' initial tentative touches or contact. Although the core temperature of newborns who are cleaned, wrapped, and healed by their parents shortly after birth appears to be slightly low than those infants that has been placed in the heated cribs, still it does not dip below the acceptable limits, or still it is better to have the baby or have the parents to hold their baby because it will promote bonding. Having a baby that requires resuscitation is inevitable. Resuscitation is a lengthy treatment, and thus we have to do something to decrease the heat loss, and this is to perform the resuscitation under a radiant heat source. So it could be a big light bulb or something that could provide heat source to the newborn. Now for the end of the first hour of life. So we're going to recheck the newborn's temperature at the end of this first hour of life. So we're going to take the temperature via axillary and not via the rectum, because if you take the temperature into the via rectum, then it will cause an intentional intestinal perforation. Now, if the baby have an abnormal or low temperature, then we have to put the baby into the heated bassinet or under a radiant warmer for extra warmth. Then, if the temperature is normal, a newborn can be swiftly cleaned to remove excess vernix caseosa and blood. Then, dressed in a shirt and diaper, then reswaddled in a snug blanket so that we can mimic the tight confines of the uterus and place the baby into the bassinet or return the baby into the mother's side. Now, what are we going to do during the first day of life of the newborn? So, a newborn's temperature is routinely taken every 4 to 8 hours of the first day of life. After that, unless the temperature is abnormally high or low, or the infant looks to be in discomfort, a daily measurement in the healthcare facility is sufficient. Now, the outcome evaluation of this nursing intervention is that by 1 hour after birth, the newborn's auxiliary temperature maintains a temperature of 98.6 degrees Fahrenheit or 37 degrees Celsius. So, at birth, a baby's body heat is conserved by a number of time-honored procedures. So, as a review, what are those? At first, we're going to wipe the baby dry. We're going to rub the baby dry gently and then reswaddle the baby. Then we're going to have the parents hold the baby and then measure the temperature, and if low, put in the heated bassinet. So, or any heat source. So that is what we're going to do. Now, for the next nursing diagnosis, it is risk for ineffective airway clearance. What are the interventions of this nursing diagnosis? The first intervention in this nursing diagnosis is first we're going to record the first cry of the baby. Because the sound of crying is produced by a current of air flowing over the larynx, a crying infant is also a breathing infant. So the louder the cry, the more likely it is that the baby is breathing deeply and forcefully. The additional carbon dioxide that makes all newborns slightly acidotic is blown off by vigorous crying. So it helps correct this condition. Although gentleness, of course, is required to ensure that an infant's transition from intrauterine to extrauterine life is as untraumatic as possible, but there is no need to stop the baby's cry. A crying baby have a positive indication. Thus, if the baby is not crying, so it can be questionable because we base the sound of crying of the baby through the infant's breathing, and it will also be beneficial for the baby. Again, there might be some instances where we have to perform resuscitation, and this is required as an emergency measure for a baby who does not breathe spontaneously or who takes a few fast gasping breaths but is unable to maintain respirations. A baby with grunting respirations should be closely monitored for respiratory distress syndrome. Now, the other nursing intervention is we're going to promote adequate breathing pattern and prevent aspiration. So how are we going to do this? So we're going to use a bulb's syringe to suction mucus from a newborn's mouth as soon as the head is born. The baby should be held for a few seconds with the head slightly dependent as soon as the body is born, also to allow more secretion drainage. That's why we have to hold the baby for a few seconds. And also, to avoid aspiration of the secretions, mucus should be eliminated from the mouth and pharynx before taking the first breath. If the infant's mouth or nose continues to accumulate mucus after these early steps, then we're going to place the baby into the warmer because it is simply not working. So what kind of bulb syringe are we going to use here? So we're going to use a bulb syringe or a soft, tiny number 10 or 12 catheter. That's what we're going to use in suctioning the mucus of the baby. We should take note to never suction vigorously since this irritates the mucosal membrane and can create an infection portal. Because of vagal nerve activation, brisk suctioning has also been linked to bradycardia in infants. And we should also note to decompress the bulb before inserting it into the infant's mouth or nose. Otherwise, if we're going to just insert it without decompressing it, the force of the compression will push secretions back into the pharynx, so mubalik ra siya, or bronchi, instead of removing them. So, dili siya mag-work if dili po natin siya i-decompress. So, we should take note to decompress it. And with a newborn that has a meconium-stained amniotic fluid, intubation may be performed so that deep tracheal suction can be conducted before the first births, reducing the risk of meconium aspirations. Surfactant administration may also be used, and it is beneficial in assisting the breathing of the infant. So we can use that. Now for outcome evaluation. So it is expected that by 5 minutes after birth, the neonate has maintained a respiratory rate of 30 to 60 breaths per minute with no evidence of retraction or grunting. Now, for our last nursing diagnosis, which is the risk for infection. So, our first nursing intervention here is that we're going to inspect and care for the umbilical cord. So, how are we going to do that? A final rush of blood from the placenta into the infant causes the umbilical cord to pulsate for a brief minute after the baby is delivered. So, we clamp the cord between the two clumps about 8 inches from the infant's abdomen, and then we cut them between the clumps. So, the clump that we usually use is the hazeltine or cane clump. And this is a permanent cord clamp that is used to clamp again the infant's cord. And it will just fall off when the umbilical itself will also pull off. We have to take note that to prevent the blood from leaking out of the placenta, so the clump on the maternal end of the cord should not be removed after the cord is cut. The mother circulation does not connect to the placenta, hence this loss is insignificant. And we should also take note that the clump is left in place since it is messy. And then inspect the cord every time that you're going to handle the baby or the newborn so that we can ensure that the cord is securely clamped. Hemorrhage could occur if a clump loosens before thrombosis obliterates the umbilical vessels. So, diba, the number of cord vessels is only 1. And there's 2 cord arteries. So, it should be counted and recorded as soon as the cord is cut, as previously described. So, cord begins to dry quickly and the vessels may be obscured by the time that the infant have first comprehensive medical examination in the nursery. And at the time, dry na. So what are the ways that we do, or the things that we should do when we change the diaper of the newborn? So in changing the diaper of the newborn, the cord care that we're going to do is we're going to wipe the cord with alcohol after each diaper change, because it speeds up the dryness process and of course it will prevent infection. So usually the cord falls off at about 7 to 10 days of life. To keep the cord dry, no, ang baby dapat should be given sponge bath rather than being immersed in a tub of water, because if we immerse the baby in a tub of water, so madugayan na naara ang cord sa baby, sa newborn, sa water, and mag-moisten po na, dili sa mag-dry. That's why we are just going to do sponge bath. And then we're going to ensure that the diapers are folded below the level of the umbilical cord so that the cord does not become wet when the diaper is wet. And of course, no, if naa ang umbilical cord sa sulod, daa siya sa inside of the diaper, then of course, the feces and the spool of the baby will be contaminating the cord. And then we have to remind the parents to keep the cord dry after they come home until it fall off. So take note that creams, lotions, and oils should not be applied near the cord since they slow the drying process and attract infection. So, when we rub alcohol to the cord location, we do it once or twice a day. Ang uban naman, other hospitals prefer to just leave the cord alone because they believe that if we're going to put any alcohol or anything in the cord, it will lead to infection. That's why they just choose to leave it there. But since in the Philippines, there's a lot of dust and medyo polluted ato na place, especially in the hospital, na sometimes we have to transport the baby. That's why we have to put alcohol so that we can prevent infection. Okay, when we transport the baby, so there might be some bacterias or viruses that would go to the cord na mag-cause infection. Any dust that will go to the cord. That's why we choose to put alcohol mostly here. I remembered because that is what the midwife here in our town said. So we mostly use alcohol in the cord. So a little pink granulating region about a quarter of an inch in diameter may remain after the cord has fallen off. So that will still remain. This too should be kept clean and dry until it heals. So mostly it heals about 24 to 48 hours. So if the ulcer has been present for more than a week, cautery with silver nitrate may be required to hasten the healing. So as you can see there, there's an example of the cord or newborn's cord that have an ulcer. Now for the second intervention to prevent infection on the newborn is we're going to administer eye care. So we use prophylactic eye therapy for newborns to protect them from gonorrheal conjunctivitis. So where did it came from? Where did the gonorrheal conjunctivitis came from? if the newborn have that. So, it is passed through the birth canal of the mother. So, many parents nowadays choose to spend, no? They choose to spend time with their child prior to the procedure where we're going to put the prophylactic eye therapy because they want to ensure that their child can focus on them because the ointment or the drops that we're going to put to the infant can cause blurry vision. And they want their baby to really see them. That's why they choose to bond with their newborn first before we put the prophylactic eye therapy. So if the parents are sure that they don't have a gonococcal or chlamydial infection, so they can completely omit the eye prophylaxis. So what are the medicines that is used in prophylaxis therapy? So during the past, we used silver nitrate, and it was the only medicine that is used for prophylaxis. But currently, now we're using erythromycin ointment, and this is the drug of choice. So most of the hospital use erythromycin. Erythromycin ointment has the advantage of killing not just the gonorrhea bacteria, but also the chlamydia bacteria. That's why it is the drug of choice. So things to consider when applying eye prophylaxis ointment. So to prevent the infection from spreading, we have to use only one tube. We have to use single tube or a pack of ointment on only one infant. And then, to apply the ointment, first we have to dry the newborn's face with a soft gauze square to prevent the skin of the newborn in becoming slippery. And then to open a newborn's eyes, we have to shield the eyes of the newborn from the overhead light and gently press the lower and upper lids together to open one eye at a time. Then we're going to squeeze a line of ointment from the inner canthus outward along the lower conjunctival sac. Then we close the eye of the newborn to let the lotion spread throughout the conjunctiva. In 1884, a German gynecologist known as Creed recommended a silver nitrate as a gonorrheal conjunctivitis prophylactic. That's why it is also known in the hospital as Creed therapy because it was recommended by a German gynecologist known as Creed. So the preventive treatment is given to babies delivered outside the hospital such as bus or maybe cab or maybe in car or in homes or in less traditional circumstances when they are being admitted to the hospital. So the last intervention is the general infection precautions. So in this, as a precaution for the infection, every baby have their own bassinet. And in there, no, because they have different bassinet, of course, dili sila maglalatnay. They will not be transmitting any infections to the other newborns. Diapers, shirts, gowns, and individual bathing and temperature-taking equipment should be stored in the bassinet's compartment. So that is the example of the bassinet. And under that, so we store the shirts, diapers, gowns, and other things of the newborn. And then, before handling an infant, healthcare personnel, parents, or siblings should thoroughly wash their hands and arms up to the elbow with an antiseptic soap so that they won't be transmitting any infection to the infant. Also, staff members with illnesses such as sore throats, upper respiratory tract infections, skin lesions, or gastrointestinal upsets should be kept away from mothers and infants until the infection has cleaned up. And as a precaution also, if a mother has an infectious disease, her newborn should be kept out of her room until the illness is no longer contagious, and we can just give them a quick snapshot of the baby, and then we give it to the mother so that she can have an idea kung gaunsa na ang iya bata or unsa na ang progress sang iyang anak. So, if the baby is breastfed and the mother cannot go to the baby because, example, she have an infectious disease, then the mother could manually express milk to keep her milk supply going while the baby is away. So breastfeeding can be resumed by the mother as soon as it is both possible and safe for her child. Despite the fact that wearing cover gowns or nursery uniforms has not been proven to decrease infections, agency staffs are frequently obliged to do. So, dapat ma-wear gid ta sang ato ang nursery uniforms. If any baby is born outside of a hospital or under conditions conducive to infection, such as ruptured membranes more than 24 hours before birth, should be kept in a closed bassinet or in the mother's room until negative cultures confirm the child is infection-free. Para dili malatnan, kay if ever gali naa ang baby, naa siya di ay infection, so ang uban nga newborn, malatnan pud siya. That's why i-separate anay if naa possibilities or risk na naa siya, if naa possibilities na naa ang newborn sang infections. So to prevent the spread of illness to other newborns, any baby who develops indications of infection, such as skin lesions or fever, should be taken to an isolation nursery or placed in the mother's room. So parents should be taught to utilize the same infection control techniques as staff members when visiting isolation nurseries. So there is no reason, no? Of course, the parents would really visit their baby. And if the baby is in isolation, so there is no reason nga dili pud sila naton ipalit na makita ang ilahang bata, ilahang anak. So they may feel the greater urge to hold an isolated newborn than ordinary parents since they have an additional reasons to be concerned about their child's health, and okay ra na makita nila, of course, no? Basta naara ta mga infection precautions. So the outcome evaluation is that the area around the cord is dry and erythema-free. There is no inflammation and drainage in the eyes, and the auxiliary temperature is maintained between 36.5 degree and 37 degrees Celsius, or 97.6 degree Fahrenheit and 98.6 degree Fahrenheit. So checkpoint, there is a question ahead. God bless. The following are the interventions that a well-informed nurse would do in a baby that have an infective air clearance, except A. Suction mucus with bulb syringe from a newborn's mouth as soon as the head is born. B. To get the mucus, the nurse must suction the mouth vigorously. And C. Record the first cry. So which among these are not an example of an interventions that a nurse must do for a baby who have an ineffective clearance? So the answer is B. To get the mucus, the nurse must suction the mouth vigorously. So it is not allowed, no? Because it can irritate the mucosal membrane of the baby and can create an infection portal. So, if you got it right, congratulations. And now let's proceed to the next reporter.